We are doing something today that I have been wanting to do for a very long time. We are going back to the source code.
Mm-hmm.
If you walk into the office of almost any surgeon, anywhere in the English-speaking world, there is a very, very high probability that a specific hefty book is sitting on their shelf.
It's the Bible. It really is. Baily and Love's short practice of surgery.
Exactly. And we aren't just skimming it today. We are cracking open the 28th edition and zeroing in on a chapter that is just so fundamental for junior doctors, medical students, frankly, for anyone who wants to understand how the body signals that something's wrong.
Yeah.
We are looking at Chapter 81, Urinary Symptoms and Investigations.
And I'm so glad we're doing this because, there's this misconception about urology.
That it's just plumbing.
That it's just plumbing. Exactly. You hear urinary symptoms, you think pipes, valves, maybe unblocking drains. And, okay, sure, there's a bit of hydraulics to it, I'll give you that.
Right.
But when you actually read this chapter, you start to see that urology is, well, it's high-stakes detective work.
That is exactly the vibe I got. It felt like a field guide to interpreting distress signals from the body. Patient comes in with one specific complaint, let's say pain in their side, and depending on the quality of that pain or where it travels, you're looking at two completely different futures for that patient. It's fascinating.
It's everything. And there's a famous saying in surgery, you cannot operate if you cannot diagnose. This chapter, Chapter 81, it's the blueprint for that diagnosis.
The foundation.
It is. We're seeing how a single tiny nuance, like whether blood in the urine is painful or painless, can just completely shift the timeline from, a routine prescription for antibiotics to an urgent oncology referral.
Okay, so here is the mission for this deep dive. We're going to treat this as a kind of ready reckoner.
A mental framework.
Exactly, a mental framework for this chapter.
Yeah.
So if you're a student, use this to revise. If you're a professional, maybe use it to refresh.
But we have to drop the disclaimer right up front, don't we?
We absolutely do.
What we're doing today is an interpretation. It's a synthesis. We are distilling the key concepts to make them stick in your head.
This is not a replacement for reading the book.
Absolutely not. Baily and Love is incredibly dense with detail, and you, 100%, need to go read Chapter 81 yourself. Consider us the companion guide, maybe, not the substitute teacher.
I like that. Think of this as the movie trailer that explains the plot so you understand the movie better when you finally watch it.
Good analogy.
And to keep us on track, we've broken this down into three main zones. First up is the symptom spectrum. So we'll be decoding pain, the language of the bladder, all that stuff.
Then the physical check, what your hands can tell you. And this is particularly important when it comes to the external genitalia.
And third, the investigation toolkit. This is where we climb the ladder from, dipping a little strip of paper in urine all the way up to nuclear physics.
Yeah, the alphabet soup of nuclear medicine.
Exactly. And we're going to try something a little interactive today. We've built in some check-in points and a couple of case studies.
So we're not just going to talk at you. I want you, the listener, to actively pause and think, okay, what would I do here before we give you the answer?
Active recall. I love it. Okay, let's dive in.
Yes.
Section 1, the language of pain. The text opens with a term that gets thrown around a lot. Dysuria.
Dysuria. And simply put, it just means pain during urination. But the description in Baily and Love, it's visceral.
It's not just it hurts.
No, not at all. They say patients describe it as passing razor blades or passing broken glass.
That is a terrifying image. Passing broken glass. Now, my mind, when I hear that, it goes straight to inflammation. The urethra is raw. So, UTI.
And look, 90% of the time you'd be right. It's usually cystitis, a bladder infection or urethritis. But, and this is why we read the book, there is a massive red flag buried in this section.
Okay.
Because if you have a very specific demographic, you absolutely cannot just assume it's a simple infection.
Ah, you're talking about the older male smoker.
Correct. If an older man, particularly one with a history of smoking, comes in complaining of that razor blade dysuria, and maybe he mentions a bit of blood in his urine, but his cultures come back negative.
So no bacteria.
No bacteria. Do not just give him more antibiotics and send him on his way.
Because that profile, older smoker, irritative symptoms, that's the classic disguise for carcinoma in situ, CIS of the bladder.
Exactly. And CIS is a nasty, high-grade, flat tumor. It spreads along the lining of the bladder like a thin carpet. It doesn't always form a big lump you can see on an ultrasound.
So it's sneaky?
very sneaky, but it severely irritates the bladder lining, mimicking a really bad infection. And if you treat that man for a stubborn UTI for 6 months, you might just lose the window to cure him.
That is a crucial distinction.
Yeah.
Okay, so from the urethra, let's move up the urinary tract to the kidneys. Now, this is an area where I feel like terminology gets really sloppy in the real world.
Oh, it does.
People say kidney pain and renal colic, like they're the same thing.
Right. They do, and it drives urologists absolutely crazy. The text is very firm on this. They are physiologically distinct entities.
They feel different because the cause is different.
The mechanism of the pain is different. Let's start with true renal pain.
Okay, so this is pain coming from the kidney organ itself.
Right. So the kidney is wrapped in this tight, non-stretchy coating. It's called the capsule. Now, if you have a condition that makes the kidney swell like pyelonephritis, a bad infection, or an obstruction causing back pressure.
The capsule gets stretched.
And the capsule does not like to stretch. It hates it. And that tension creates a steady, dull, gnawing ache right in the loin.
So it's constant.
It's constant. It's the kind of pain that just sits there and grinds away at you. It doesn't come in waves.
Okay, so that's renal pain. Now, contrast that with ureteric colic. This is the classic stone pain.
Yes. So the ureter, the tube from the kidney to the bladder, it's a muscular tube. Its job is to push urine down. Now, if a stone gets stuck,
The ureter freaks out.
it goes into overdrive. It starts what we call hyperperistalsing. It's squeezing violently, desperately trying to push that rock through.
So it's a muscle spasm.
A violent spasm, and that's why it is colic. It comes in these intense, unbearable waves. The patient will be rolling around on the bed, they can't get comfortable, then it might ease off for a few minutes, and then wham, it hits them again.
And the radiation pattern is the key here, isn't it? With that classic anchor, loin to groin.
Loin to groin, you have to
Right.
burn that into your brain. It starts in the back, and it shoots down towards the testicle in men or the labium in women. That's the classic nerve pathway.
But, okay, there is a check-in point here.
Yeah.
There's a rule in the book about where ureteric pain never goes.
Yes. This is so important.
I highlighted this because it's such a useful rule of thumb for ruling things out. The text says, ureteric colic never radiates to the back of the leg.
Never. And this is a very common point of confusion. A patient comes into the emergency room. They're clutching their back. They're in absolute agony. But if they say, "Doc, the pain is shooting down the back of my thigh right down to my heel," you have to stop thinking about kidney stones.
Because that's not the ureter's nerve path. That's sciatic nerve distribution.
Exactly. That is a musculoskeletal problem. That's slick disc, that's nerve root compression. The ureter simply isn't wired to send pain signals down the back of the leg. So if it's back of the leg, think spine. If it's groin or testicle, think stone.
That is a golden nugget for anyone working in triage. Just briefly, before we leave pain, let's touch on what you called the black hole of urology, the perineum.
Ah, the perineum. The area between the scrotum and the anus. Pain here is just notoriously difficult to pin down and treat. Historically, men with pain in this area were just told they had prostatitis.
Inflammation of the prostate.
Right. But the text suggests we're moving away from that label now, especially if there's no clear sign of infection.
So if you test the urine and there are no bugs.
Exactly. If you culture the urine, you express some prostatic secretions, you look under the microscope and find no bacteria, it is technically incorrect to call it prostatitis. We now label that chronic pelvic pain syndrome, or CPPS.
And that's not just semantics. It changes the treatment.
Completely. Because if you label it itis, what do? You throw antibiotics at it. But if it's CPPS, the antibiotics won't work. You need to be thinking about pain management, physiotherapy, maybe alpha blockers to relax the muscles.
It's a shift from kill the bug to manage the symptoms. Okay, I think it's time for our first check-in. I want you, our listener, to visualize a patient.
Go for it.
Scenario. A 45-year-old woman comes into your clinic. She has a dull, constant ache in her left loin that's been there for about 24 hours. It doesn't come and go. It's just there. And she has a high fever.
Is this likely a stone passing down the ureter, or is it something else? Pause and think about the quality of that pain.
So what's the verdict?
Well, based on what we just discussed, that phrase constant dull ache just screams capsule stretching to me, not the waves, the colic of a moving stone.
And the fever.
And the fever points strongly towards infection, so I'm going with pyelonephritis, a kidney infection that's causing the whole organ to swell up.
Spot on. The lack of colic steers you away from a migrating stone. The constancy of the pain points directly to organ swelling. You've just diagnosed the patient without even laying a hand on them.
Fantastic. Okay, let's move on to section 2. LUTS, that's lower urinary tract symptoms.
Right, and this section really represents a huge cultural shift in medicine. For decades, if an older man had trouble peeing, we used one specific word for it. We said he had prostatism.
Which automatically implies the prostate is the villain.
Exactly. But Baily and Love is very clear on this. Prostatism is now considered an obsolete term. We have effectively banned it from our vocabulary.
Why? Is it just about being politically correct with our terms?
No, it's about safety. It's a clinical safety issue. If you label a patient's symptoms as prostatism, you are assuming the diagnosis, which is usually benign prostatic hyperplasia, or BPH, before you've even done the work.
I see.
But the symptoms of, say, frequency or urgency or a weak stream, they can be caused by a dozen different things. A urethral stricture, a bladder tumor, a nasty UTI, even neurological conditions or diabetes.
So by using the word prostatism, you're essentially putting on blinders. You stop looking for other causes.
That's it, exactly.
Okay.
So instead, we now use the neutral term LUTS. It describes what is happening, the symptoms, without assuming why it's happening.
And the best way to get your head around LUTS is the metaphor the book uses, which I love, the tank and the pipe.
It's a brilliant analogy. It just turns the whole lower urinary system into a simple engineering diagram that anyone can understand.
Okay, so break it down.
The bladder is the tank. Its job is to store urine at a very low pressure. The urethra and the prostate that wraps around it in men is the pipe. Its job is to let the urine out when it's supposed to.
So we can group all these disparate symptoms into either tank problems or pipe problems.
Precisely. Let's look at storage symptoms first. This is tank failure.
Yeah.
If the tank is failing, it can't hold on to the urine properly, so you get frequency, meaning you're going to the toilet too often.
Nocturia, waking up at night to pee.
Urgency, which is that sudden, desperate, gotta go right now feeling. And of course, incontinence.
Those are all signs the tank is either irritable or twitchy or maybe just too small.
Correct. Now, what about voiding symptoms? This is pipe failure.
The pipe is blocked.
If the pipe is blocked, you can't get the fluid out efficiently. So you get hesitancy, which is that delay when you're waiting for the stream to start.
That's a Greek stream.
Straining, where you have to use your abdominal muscles to push. And intermittency, where the flow kind of stops and starts.
And then there's that third little category, the post-micturition symptoms, the I'm not quite done yet feeling.
Right, the sensation of incomplete emptying or that frustrating post-micturition dribble.
Okay, let's apply this to a fictional case study to see why making this distinction is so important. Let's call him Mr. Jones.
Okay.
Case study. Mr. Jones is 70 years old. He comes in and says, "Doctor, it takes me forever to start peeing and I have to push really hard." But then he adds, "And I'm waking up 4 times a night to pee, and I nearly wet myself on the way to the bathroom this morning."
This is a perfect, classic, mixed LUTS picture. Let's break it down using our analogy. The hesitancy and the pushing.
That's a voiding symptom. That's a pipe problem.
Absolutely. Almost certainly his enlarged prostate is blocking the way. It's a bladder outlet obstruction.
But the waking up at night and that sudden urgency...
That's storage. That's a tank problem. His bladder is irritable.
So why does he have both? Is it 2 separate issues?
Not usually. What often happens is the obstruction, the pipe problem, causes the bladder muscle to work so incredibly hard to push urine past the blockage. Over months and years, that muscle gets thick and hypertrophied. It gets twitchy.
So it becomes an overactive bladder.
Exactly. So even though the root cause is the pipe, the symptoms the patient is suffering from most are actually coming from the tank.
And that matters because if you just treated the prostate, say, you did surgery to open up the pipe.
You haven't necessarily fixed the twitchy, irritable bladder overnight. He might still wake up 4 times a night for a while because his bladder is still in that overactive state. You need to warn him about that, or maybe even treat the overactive bladder separately with medication.
It's not just plumbing, it's physiology. That's why separating LUTS into storage and voiding is so critical.
It's everything for diagnosis and management.
All right, let's move on to section 3. This is the big one, the cardinal sign, haematuria.
Blood in the urine. And if there's one thing, just one thing you take away from this entire deep dive, it's the mnemonic for the causes of haematuria. TIN.
TIN.
T for trauma, I for infection, and N for neoplasm, which is, a new growth, or cancer.
And that applies everywhere.
Anywhere along the line. From the kidney, down the ureter, in the bladder, the prostate, the urethra, anywhere you can get blood from, TIN applies.
Okay, now we need to talk about the painless paradox. I have to say, this was the most counterintuitive part of the chapter for me.
It is strange, isn't it? As human beings, we are programmed to associate pain with danger. If something hurts, we think it's bad. But in urology, specifically with blood in the urine, the opposite is often true.
So you're telling me if a patient comes in peeing blood and is screaming in agony, that's good.
Relatively speaking, yes. Painful hematuria is usually a kidney stone scraping its way down the ureter, or a raging hemorrhagic cystitis. The body is screaming about a mechanical problem or a bad inflammatory process.
But if a patient walks in totally calm and says, it's strange, I peed what looked like bright red wine this morning, but I feel totally fine. No pain at all.
That is the nightmare scenario. Painless visible hematuria is cancer until proven otherwise. End of story.
The statistic in the book is stark.
It is. The text states that the cancer detection rate in patients with visible hematuria is around 20%.
1 in 5. That is terrifyingly high.
It is. And you compare that to non-visible hematuria, the blood that's only found on a dipstick test. There, the cancer rate is less than 5%. So visible plus painless equals maximum alert.
Right. And speaking of things that look like blood, the book has a fascinating little section on discoloration traps.
Oh, the imposters.
Things that turn your urine red but aren't actually blood.
The most common one is the beetroot test. If you eat a lot of beetroot, the betalain pigment can be excreted in your urine, and it looks exactly like fresh blood. It causes a lot of panic.
And medications can do it too.
Oh, definitely. Rifampicin, which is a drug for tuberculosis, famously turns all your body fluids orange-red. Urine, tears, sweat, everything. And nitrofurantoin, a common antibiotic for UTIs, can turn urine a dark brown.
There was one other mimic in there that sounded like something out of a war story, the Soldier's March.
Ugh, March hematuria. It's actually a bit of a misnomer. It should really be called March myoglobinuria.
Myoglobin, not hemoglobin. So what's the mechanism there?
It typically happens in, say, long-distance runners or soldiers on a long march with heavy packs on hard ground. The repetitive, heavy impact can destroy red blood cells inside the capillaries of the soles of the feet.
Wow.
Or it can cause breakdown of muscle tissue, which is called rhabdomyolysis. This releases a protein called myoglobin from the muscles.
And myoglobin looks like hemoglobin to a urine dipstick.
Exactly. The chemical strip just reacts to the heme part of the molecule, so the dipstick lights up and says blood plus plus plus. But if you were to look at that urine under a microscope, you wouldn't see any red blood cells, just the pigment.
Fascinating. So the dipstick can be fooled. Okay, before we leave this section, let's do a quick check-in on the investigation side of things.
Let's do it.
Scenario. A 50-year-old man has one episode of painless, visible blood in his urine. He feels perfectly fine. You send him for an ultrasound of his kidneys and bladder, and it comes back completely normal.
Are you done? Can you reassure him and send him home?
This is probably the single most common and dangerous mistake made in primary care. The answer is an emphatic, absolutely not.
Why not? The ultrasound is normal. His kidneys look fine.
Ultrasound is great for looking at kidneys. It's pretty good at seeing if the bladder is full or empty. It is terrible, however, for looking at the bladder lining. It simply cannot reliably see small tumors on the bladder wall, and it's especially bad at seeing flat ones like CIS. You have completely missed the bladder.
So what is the mandatory, non-negotiable next step?
Cystoscopy. You have to put a flexible camera inside the bladder and look around. If you don't do that, you have not investigated hematuria, period.
Loud and clear. Ultrasound's not enough. Okay, let's move to section 4, the physical check, specifically the external genitalia.
Right. And this section really oscillates between, routine findings and true surgical emergencies. Let's start with the big emergency, testicular pain in a young male or an adolescent.
The phrase timus testis comes to mind. We're obviously worried about torsion.
Torsion of the spermatic cord. The testicle basically twists on its own blood supply, choking it off. You have a window of about 4 to 6 hours before that testicle starts to die and become gangrenous.
The text describes a very specific physical sign to look for, the clapper bell sign.
Yes, it's a great visual. Picture a church bell with the clapper hanging inside. The clapper hangs vertically. That's how a normal testicle hangs in the scrotum.
Right.
In torsion, the twisting of the cord pulls the testicle up and also twists it sideways. So it ends up lying horizontally and it rides high in the scrotum.
So if you see a high-riding horizontal testicle in a boy with acute pain, that's torsion. Now, the next question is crucial. Do you send him for an ultrasound to confirm it?
No, this is another one of those absolute rules. If your clinical suspicion is high, you do not wait for imaging. You take the patient straight to the operating theater.
Don't waste time.
You don't waste time. If you wait 2 hours for an ultrasound slot and then another hour for the report, you might lose that testicle. It is far better to operate and find out you are wrong than to wait for confirmation and be right too late.
So the exploratory surgery is the diagnostic test in this case. That's intense. Okay, let's talk about the less urgent things like lumps, hydroceles versus varicoceles.
A hydrocele is simply a collection of fluid in the sac around the testes. And the key diagnostic tool here is not some high-tech scanner, it's a simple flashlight.
Grants illumination.
Exactly. You go into a dark room, press a bright light against the scrotal swelling. If it glows a brilliant red, like a lantern, it's fluid. Light passes straight through fluid. If it's dark and opaque, it's a solid mass, and that immediately worries us about testicular cancer.
And the varicocele, that's described as a bag of worms.
A classic description. It feels like a bag of wriggling worms above the testicle. It's just dilated veins. And there's a neat little anatomy lesson here. The text notes that about 90% of varicoceles are on the left side.
Why the left?
It's all about the plumbing again. The right testicular vein drains directly into the big vena cava. It's like merging onto a major highway. This is a nice, easy, angled entry. The left testicular vein, on the other hand, has to drain up into the left renal vein at a sharp 90-degree angle. It's a much harder path, there's more resistance, so the valves in the vein fail more often and the blood pools, causing the swelling.
So a left-sided varicocele is common and usually not worrying. But what if you find a solitary right-sided varicocele?
Now that is suspicious. Since it's so rare anatomically, you have to ask yourself, is something compressing or blocking the vena cava higher up, like a large kidney tumor growing into the vein? A new right-sided varicocele needs a CT scan of the abdomen to rule that out.
Good catch. Finally, let's just quickly touch on the penis. Two terms that sound alike but are clinical opposites. Phimosis and paraphimosis.
Phimosis is a tight foreskin that cannot be retracted back over the head of the penis. It can be a problem, but it's usually an elective, non-urgent fix. Paraphimosis is when that tight foreskin is forced back behind the head, the glands, and then it gets stuck there.
It gets trapped in the retracted position.
And it immediately acts like a tourniquet. It starts to squeeze the penis. The head of the penis starts to swell up with trapped blood, which makes the constricting ring even tighter, which causes more swelling. It's a vicious cycle.
And it can cut off the blood supply.
It can. If you don't reduce it quickly, the head of the penis can become ischemic and even gangrenous. It is a genuine urological emergency.
And one last injury that made me cross my legs while reading. The penile fracture.
The eggplant deformity. This is a dramatic injury. It happens when an erect penis, usually during vigorous intercourse, accidentally hits the partner's perineum or pubic bone. The tunica albuginea, the tough, fibrous sheath that holds the erection, snaps.
The patient actually hears a snap.
A loud crack, or pock, yes. It's followed by immediate loss of the erection and then massive, dark purple swelling and bruising. It looks just like an eggplant. And that, again, requires immediate surgery to find the tear and stitch it up.
Note to self. Be careful. Okay, let's move to our final section, Section 5, the investigation toolkit. This is the ladder of truth.
We start at the bottom rung with the simple urine dipstick, the screening scout. Then we can move up to things like urine cytology.
This is basically a pathologist looking for cancer cells that have been shed into the pee.
Yes. But Baily and Love puts a big flashing caveat here. Cytology is a bit like a sniper. It is very, very good at spotting high-grade cancer cells because they look very ugly and abnormal and they tend to shed easily. But for low-grade tumors, it misses them all the time.
So a negative cytology result doesn't mean no cancer?
Not at all. It has a very high false negative rate for low-grade disease. You can't use it to rule out cancer.
What about tuberculosis? The book mentioned a very specific protocol for testing for TB of the urinary tract.
It did. The problem with TB bacilli is that they are shy. They're shed intermittently and in low numbers. So the standard protocol is EMU times 3.
Early morning urine, 3 days in a row. Why early morning?
Because while you sleep, urine sits and collects in your bladder for 6, 7, 8 hours. This allows the bacteria to accumulate. So that first void of the day has the highest possible concentration of bugs, giving the lab the best chance of finding them.
Makes perfect sense. Okay, let's talk about the blood test that everyone knows and many people fear. The PSA, prostate-specific antigen.
Probably the most controversial and misunderstood test in the whole chapter. The most important takeaway is right there in the name. It is prostate-specific, not cancer-specific.
Meaning it tells you something is happening in the prostate, but it doesn't tell you what is happening.
Exactly. A benignly enlarged prostate, BPH, leaks PSA. Prostatitis and infection causes a huge leak of PSA. Even simple things like ejaculation or vigorous cycling can temporarily bump up the PSA level.
So if a patient has an active UTI, checking their PSA is a terrible idea.
A terrible, terrible idea. The inflammation will make the PSA skyrocket. You'll get a reading that makes you think he has metastatic cancer. The rule is you must wait at least 6 weeks after the infection has completely cleared before you check the PSA. You have to let all that inflammatory noise settle down.
Got it. Okay, imaging. We have this huge menu: ultrasound, X-ray, CT, MRI.
Let's try and simplify it.
It's safe, no radiation. It's great for looking at the kidneys for things like hydronephrosis swelling and for checking bladder volume. It's not great for seeing stones or the ureters.
Okay. And CT?
The CTKU-B, which is a non-contrast scan, is the gold standard for renal colic. It spots almost all stones, even the ones that X-rays miss, and it is incredibly fast.
In MRI, where does that fit in?
MRI is the king of staging, specifically for prostate cancer. We now use something called an MP-MRI, or a multiparametric MRI. This gives us the PIR-ADS score.
Which is basically a risk score for cancer.
It is. It's a score from 1 to 5. PIRADS-1 is very unlikely to be cancer. PIRAD-5 is highly likely to be clinically significant cancer. It's revolutionary because it allows us to do targeted biopsies of suspicious areas rather than just poking the prostate blindly and hoping we hit the tumor.
Finally, we arrive at the heavy artillery: nuclear medicine. The text throws this alphabet soup at us: DMSA, MAG3. I want to spend a minute here because this confuses everyone.
It does, but it's actually simple if you just ask one question.
Yeah.
Am I interested in the kidney's anatomy and scars, or am I interested in its physiology and flow?
Okay, let's start with DMSA.
DMSA is a static scan. Think of it like a photograph. The radioactive tracer they inject is chemically designed to bind to the cells of the kidney cortex, the working tissue. It gets taken up and it just sticks there.
So you're essentially painting a picture of all the functioning tissue.
Exactly. So if there is a scar, say, from a bad childhood infection where some of the tissue died, the tracer won't stick there. On the scan, you'll see a cold spot or a bite taken out of the kidney shape. DMSA is the gold standard for detecting scarring.
Okay, so DMSA equals scars or structure. I've got that. Now, what about MEG3?
MEG3 is a dynamic scan. Think of it like a movie, not a photograph. The tracer they inject for this scan is designed not to stick. The kidney grabs it from the blood and then rapidly excretes it into the urine.
So you watch it flow through the system.
You literally watch the bolus of radioactivity travel from the blood, get taken up into the kidney, and then flow down the ureter and into the bladder. And you plot this activity over time to generate a graph called a renogram curve.
Right. Let's visualize that curve.
In a normal kidney, the curve goes up sharply as the kidney takes up the tracer, it hits a peak, and then it drops off rapidly as the tracer is washed out into the bladder. Now, if the curve goes up and just stays up...
It means the tracer isn't leaving the kidney, it's blocked.
Exactly. That is the classic obstructed curve. The tracer is trapped.
Okay, I think I'm getting this. Let's do a final check-in to lock it in.
Fire away.
Scenario A. A 5-year-old girl has had 3 bad kidney infections. The pediatrician is worried and wants to know if she has any permanent kidney damage. Which nuclear medicine scan do you order?
Permanent damage means scarring. We want a static picture of the kidney tissue. You order DMSA.
Perfect. Scenario B. A 40-year-old man has a dilated, swollen-looking kidney found on an ultrasound. We don't know if it's a tight blockage that needs surgery or if it's just a baggy, lazy system that drains slowly but is ultimately safe. We need to see how well it drains.
We need to see flow. We need the movie. We order a MEG3 scan, and we usually give a diuretic like furosemide partway through to really push the system. Yeah. If the curve still doesn't drop, he's obstructed and needs surgery. If it washes out, he's safe.
DMSA for scars, MEG3 for flow and obstruction. That actually makes sense now.
See? It's all about the mechanism of the tracer. Stick or flow.
We have covered a massive amount of ground today, from the razor blades of CIS all the way to the curves of a renogram. Let's wrap this up with our outro. What are the big, high-yield anchors you want our listeners to walk away with?
Okay, let's do the rapid recap.
Pain. Renal pain is constant. Think capsule stretch. Ureteric pain is colicky. It comes in waves. And remember, ureteric pain never goes to the back of the leg.
Number 2, LUTS. Don't say prostatism. Think tank versus pipe. Storage versus voiding.
3, haematuria. The painless paradox. If it bleeds without pain, you have to think cancer immediately. And cystoscopy is mandatory, not optional.
4, the emergency. A high-riding horizontal testes in a young boy is torsion until proven otherwise. Operate, don't wait for imaging.
And finally 5, the nukes. DMSA sticks, so it's for scars. MEG3 flows, so it's for obstruction.
That's a great summary.
Yeah.
And I'd like to leave our listeners with one final thought, something to chew on that the chapter really just alludes to. We talked about urine cytology, looking for cancer cells and how it's not perfect.
Yeah.
It feels like we're on the cusp of a revolution there.
We absolutely are. We're in the era of the liquid biopsy. The chapter mentions cytology, which is looking at cells visually under a microscope, but the future is molecular.
What do you mean by that?
We're now looking for tiny DNA fragments or specific genetic mutations that are shed by tumors into the urine. Imagine a world where, for many patients, we don't need to put a cystoscope inside you to check for bladder cancer. We just analyze the genetic code floating around in your urine cup.
The search for the perfect p-test.
That's it. We aren't quite there yet for routine screening for everyone, but that is where the horizon is.
I love it. Well, as we said at the very start, this was the trailer. The movie is Baily in Love, Chapter 81. Go and look at Figure 81.28 and see those rhinogram curves for yourself. Go look at the images of the Bosniak cysts in Figure 81.24.
It really is the best way to solidify everything you've just heard. It makes it all click into place.
Thank you for diving deep with us today. Stay curious, keep diagnosing, and we'll catch you on the next one.